discussion, no presentation, and no proposal on anything to do with medicine or healthcare. It is not complete without rural healthcare services. India is a land of villages. The majority of the population live in our villages. As regards to rural health service, the obvious question from the viewers would be, where does medical education restructuring curriculum stand with regards to betterment of rural healthcare services? I'll make it short and simple. The government, our government, which rules this nation, has taken giant steps towards betterment of rural healthcare service. They are doing. Every government does. Whether it is in setting up of a large number of district hospitals or rural side hospitals, whether it is in the pushing forward with satellite-based telemedicine, so many things the government is doing. Having said that, however, there are certain problems that are associated with rural healthcare services. One of them is the major is there are two major problems. One is accessibility. That is, these are far-flung areas geographically. The nearest centers would be slightly far away, and transport is an eternal problem. Yes, no doubt the ambulances, the national health services ambulances have been spread out all across the country. I do not deny any of those things. Having said that, accessibility is a problem. The main problem is manpower. The perennial complaint is about lack of doctors in the rural area. Put it in simple English, doctors are not willing to go to rural areas. How does MERC address this final question? See, here I have to be impartial. I'll be open. I am a cardiothoracic surgeon. I have been trained to do heart surgery, open heart surgery. If tomorrow I am asked to go to a rural service, I will be honest and frank. If I am asked to go to a rural service and day in and day out, if I am asked to treat cold, cough, fever, headache and body ache, that would not be possible. It would not be fair. So, this is a very tricky situation. To force doctors to go as a part of bond, that this, etc., compulsory rural service, if you don't do rural service, you'll be penalized 20 lakhs, 25 lakhs. Those things, again, on a personal note, I feel that these are draconian policies. There has to be a very acceptable solution. What is the solution? At one end of the spectrum, MBBS and fully qualified doctors are not ready to go. Reasons whatever they may be, lack of infrastructure, let's not discuss that. On the other hand, the present workforce comprises of nurses, ANMs, who are somehow trying to manage. But then, it's obvious, we all know that the quality of service cannot be, so we have one end of the spectrum, the doctors, another end, the nurses. What is the via media? The via media, what MERC feels is the BSc and MSc medicine graduation and postgraduate holders, these degree holders, whom we have already defined as DEFINED, defined as quasi-medical professionals. The BSc and MSc medicine courses which MERC has proposed, these would bring out highly trained, highly skilled quasi-medical professionals who would be a great replacement for the doctors. That is to say, there is no availability of doctors. That lacunae, that deficiency would be replaced, MERC feels, definitely by introducing the BSc and MSc medicine postgraduate holders, who, I repeat, would be highly trained and would be capable of handling a vast variety of cases at the rural level. Of course, under supervision. It is not the case that they would be doing independently. That availability, what needs to be provided, it can be provided by medicine graduates and postgraduates who, as we already said, would be designated as the health officers, junior health officers, and senior health officers in the year 1, year 2, and year 3 of their rural service. So, in front of you is a slide. The post BSc and MSc medicine health officers or junior or senior health officers would be posted to the primary health center or the community centers. They would have the backup and support of the nearest specialty hospital, which would be designated as a nodal or zonal hospital. Patient on arrival would be examined by the health officer, who arrives primarily at a broad clinical diagnosis, discusses with the nodal center regarding clinical findings. Nodal center physician advises certain lab investigations and radiological investigations, say a chest X-ray or whatever it is. Health officer performs the above investigations and sends the result to the nodal center via telemedicine. Specialist advises initiation of specific treatment. Health officer initiates the therapy as supported by nurses and auxiliary nurse and midwife. Nodal center physician inquires the progress once every 12 hours through telemedicine rounds. Patient improves, we are happy, they are discharged from the PHC after completion of treatment. If there is no improvement, the patient is shifted to the nodal center.